Hello friends, today when I am recording this video, it is the day when we are celebrating Deepavali in India. So we are today looking at a case who had a traumatic subluxation of crystalline lens, and this is frequently a problem when you have zonular deficiency seen in these cases, and the lens not only decenters but also gets cataractous. And then the savior is this CTR or capsular tension ring, which is basically a circular device which has blunt tips with eyelets, and this can expand the capsule and providing a centrifugal force. It tightens the zonules, and at the cost of the rest of the zonules it provides the support in the area where the zonules are deficient, and the capsular bag can be brought into the center, and small amount of subluxation can be managed with retaining of the bag, and subsequently the IOL can be implanted into the correct anatomical position. So this was a 45-year male who sustained some trauma, and you can see subluxation and zonular dehiscence in the inferotemporal part. The lens is cataractous. We can also see some amount of sphincter damage. So the surgery starts with a clear corneal incision, a side port, and we can also make out the lens itself is shaky. There is a deficiency of the capsule in the inferotemporal and temporal quadrants. So just like a routine situation, a capsular excess has been done very carefully, making sure that none of the zonules which are remaining are stretched or broken. A capsular tension ring is to be implanted, and something which I am doing is we are starting from the portion where there is deficiency, but recently I have realized that it is better to start from the portion where the zonules are intact. And this is because when you start injecting, there is hardly any pressure or stretch on the zonules. By the end, when you are actually implanting the ring into the bag through the excess margin, then there is maximum amount of force, and usually this is directed away from the area of the dehiscence if we are starting from that portion where the zonules are intact. So the technique which I have shown, I am suggesting that we should be doing it quite opposite to it. So once the bag has been stabilized, carefully nuclear disassembly and phacoemulsification is being done. Once the nucleus is out, implanting IOL, and because there was a vitreous prolapse through that area, so we can also see that doing a vitrectomy in the pars plana area, that brings back the bag and the IOL is centered better. Now creating a PVD, which is an important part for these patients, otherwise later on they develop macular pucker and ERM formation. So triamcinolone has been used, PVD has been created, and the core vitrectomy has been completed. This is the post-op day 1 picture, and the BCA was 6.9, unaided vision was 6/12, and patient is doing fine. Thanks.